So Dr. SITESH VATS, yeah. So we have Dr. SITESH here who will be delivering a talk on severe mechanical ptosis, a delayed presentation of giant upper eyelid cyst. Over to you.
Good morning all. I will be presenting severe mechanical ptosis, a delayed presentation of giant upper eyelid cyst. There is no conflict of interest to disclose, no financial disclosures. Cystic lesion on eyelid is very common. Those cystic lesions can occur anywhere on the body, but their presence on eyelid leads to early presentation in clinics. On eyelid, they can cause mechanical ptosis or astigmatism leading to temporary visual disturbances. Their sizes vary from few millimeters to centimeters. Mostly benign cysts are asymptomatic and usually ignored by patients and sometimes misdiagnosed. So I am presenting a case of painless progressive cystic mass of left upper eyelid in a 52-year-old male since 5 to 6 years, grown from few peanut size to few centimeters in 1 year duration, causing severe mechanical ptosis. He was on some homeopathic medication, which details was not known, so no improvement seen, so he came to our OPD. There was no history of penetrating trauma or previous surgery of either eye, no history of any systemic illness or any other cystic lesion on other parts of body. So on examination, large round mass of approx 2.5 centimeter covering lateral 2/3 of the left upper eyelids, which was causing severe ptosis, and xanthelasma on both upper eyelid. On palpation, well-defined cystic, but firm and free from skin and bony margins. There was no sign of inflammation and the overlying skin appeared normal. There was nil vertical and horizontal fissure height. There was nil LPS function and there was good transillumination. These are external photographs of anterior, medial and lateral view with good transillumination. Rest of the anterior segment was within normal limit. Posterior segment of both eye was within normal limit. So my differential diagnosis comes to epidermal inclusion cyst, sebaceous cyst or dermoid cyst. And provisional diagnosis comes to left upper eyelids benign cyst, most probably epidermal inclusion cyst with both upper eyelid xanthelasma. So I planned for surgical excision of left upper eyelid cyst under local anesthesia with histopathological confirmation. Investigation was within normal limit except lipid profile which was deranged. This was surgery day with mass excised measuring 2.5 centimeter. This was in day 0 post-op picture showing mild ectropion of the upper lid. Histopathological examination shows epidermal inclusion cyst with no dysplastic or malignant features. So final diagnosis was epidermal inclusion cyst of tarsal plate of the eyelid. Photomicrograph shows abundant keratin flakes and a stratified squamous epithelium with granular layer. This was first follow-up on day 10, showing mild ptosis in the left eye. This was follow-up to day 30 with almost equal level of both upper eyelid. So benign cystic lesion of the eyelid are very common, but epidermal inclusion cyst compromises minor portion. As per study of Poetel, only 8% of the epidermal cyst among are benign masses of the lid. Incorporation of ectodermal elements during embryonic development or trauma or surgery leads to their development, which remain stable and can progress over years but have no predictive risk factor for that, which are predominantly seen both men and women of age group of 20 to 40. So epidermoid cysts consist of keratinous cyst covering a stratified squamous epithelium without adnexal structures. Dermoid cysts contain keratin, sebaceous gland, hair follicles and adnexal structure within the wall of a stratified squamous epithelium. Sebaceous cysts contain sebum and usually blocked punctum is found on the surface. So complete excision of the cyst is recommended, as in incomplete excision can cause recurrence. In total excision is very difficult. Wedge excision or partial tarsectomy should be done to prevent recurrence. Good functional and cosmetic outcome should be our motto, which was achieved in our patient. Thank you.
Excellent. I really love the surgery. Yeah. So what was the duration of the cyst appearing so large?
It was since 5 to 6 years, but gradually developed in last 1 year.
Okay.
It was from peanut cells, which developed to more than 2 to 3 centimeters.
Yeah, so in my practice, I've seen this epidermal cyst. It actually rapidly collects the fluid, you know, and it becomes so big. Sometimes you're actually thinking it could be some rapid progressive malignancy of the eyelid, you know, but
Yes,
then
ma'am.
the transluminal illumination positivity and stuff. Surgery is excellent. So
Thank
one
you,
thing that I would have done here is I would have taken the incision over the lid crease. You know, like just a lid crease incision, not too below, and then that's the only thing that I would have
Lid
done
crease was very
differently.
difficult to delineate in
Delineate,
this
yeah,
patient.
because it was stretched.
Yes,
I
ma'am.
understand, yeah. Thank you.
Usually what I have noticed in upper lid, we need to do a partial tarsectomy, which you have done.
Yes,
I've
ma'am.
seen that most of these epidermals is usually adherent to the tarsus in the upper lid. But in lower lid, it is not there. I have not come across any lower lid epidermal cyst adherent to the tarsus, right?
Yes.
Right, that's all. I think nicely done, nicely presented.
Yeah, thank you, sir. Thank
Very nicely done. And you said that the LPS action was poor. You could make out.
Initially it was poor, but
So
post
after
surgery,
you did the surgery, did you
yeah, it was
compare?
good, ma'am.
It was good. So
It was
because
almost of the normal.
that was good. You should have very
The
nicely done.
surgery has been done by you.
Yes, ma'am.
Very nice surgery.
Thank you.
He's our student from our college, so I'm proud. That's good.
And he has documented it so well.
Yeah.
Clean
Thank you.
documentation.
What precautions do you take once it ruptures? Suppose this was very nicely, completely done. So what normally I would ask, like what, any specific, suppose it ruptures while you are taking it out. Normally dermoids also so many times they rupture, big ones, SRS, anybody doing it can rupture from us. So what precautions do you take?
No, if it is rupture, it is nice only. The surgery becomes so easy.
Easy, that way is
But
okay,
only for documentation, and when we are teacher and we are mentoring our students, we say, no, it should be a good surgery, no rupture. But any cyst, if it ruptures, it becomes very easy. The surgery becomes minimally invasive.
So it's usually adherent to the tarsal plate. So at that
But upper
time,
lid, usually it is adherent, and we need to scrape off some amount of the tarsus.
yes, ma'am.
When a senior surgeon has a rupture, it's called planned decompression.
Yeah, actually, rupture is like so easy. So, but then it's a surgeon's ego, you know, I just want to take out the cyst without rupturing. It's all about our ego. But actually, to get it out, easier is to even aspirate the thing inside. And yeah, rupture is always a blessing in disguise. Yeah.
Sometimes I aspirate and hold it with the artery only to decrease the size, to make it minimally invasive.
But the material is very thick, so it will be
You
difficult
should
to
give a good
aspirate.
betadine wash also if it's a dermoid and if it ruptures on the table. You should make sure.
But if it is a hydrated cyst, if a hydrated cyst rupture, you cannot take a chance. So you have to give what? Steroids. Because it can lead to anaphylaxis. So all these things are there. If it's a simple epidermal cyst, when if it is cystic circus or a hydrated cyst, something ruptures, then you don't take a chance. You ask the anesthetist anyone to give immediate IV steroid. And also sometimes I wash it with the steroid.
So in my surgery, if a cyst breaks, I'm really sad. Although it's good for the patient. To get it, yeah, and you feel like so good, and especially this big, humongous cyst, it's amazing. It's
Sometimes
amazing.
it's so adherent down to the base that you try your best, but it bilkul last mein jaake it will rupture when most of it has come out, and last with that adherent part you are trying and it gets